So today we'll talk about obstructive lung diseases, which includes mainly two diseases, which is COPD and asthma. Uh, we talked about some of the topics I'm going to talk today yesterday at the small group. So we're just going to go through some of the topics. Going to be like just repeating what we talked yesterday. So the goal. So we'll review uh, pulmonary function tests briefly. Uh, we'll take a look at the difference on the PFTs, difference between obstructive and restrictive lung diseases. We'll talk about COPD, risk factor, pathogenesis, and diagnosis. We'll talk a little bit about one of the types of COPD, which is caused from alpha antitrypsin deficiency. And then we'll review the COPD and asthma medications, which has a big overlap. So these are the lung volumes from the basic physiology. So the tidal volume, that's what we're breathing like moment to moment, in and out. That's the tidal volume. If you take the there is a total vital lung capacity. If you take a deep breath besides tidal volume and then exhale all that, that's going to be total lung capacity. And then the differences here, there's inspiratory capacity, expiratory reserve volume, and then total lung capacity, which you cannot really exhale the whole air because some air is still going to stay in the airways and then a little bit in the alveoli and small airways. So this is how a normal spirometry looks like. Spirometry is easy thing to do. It can be done in the office. It doesn't require any complicated equipment. It's usually not done in the hospital because people in the either have other active medical problems which may affect the results, or they have acute exacerbation, flare-up of their pulmonary disease. So then pulmonary function tests, they not very reliable. So it's usually done when patients are like in the stable condition otherwise. So as you can see here on the first picture on the left, like forced expiratory volume in 1 second, that in 1 second you exhale most of the air you have in the lungs. So lung volumes measurements are important when spirometry show decreased forced vital capacity. I'm not sure. I think it's wrong there. It's either forced expiratory capacity. I think one in 1 second. Um, there is a way to measure total lung capacity, and body plethysmography is the main way how you do that. You basically using the physics law that the pressure and then there is a correlation between the volume and the pressure. And then total lung capacity is the key volume which they determine from this test. We talked yesterday about diffusion capacity of carbon monoxide. So it's basically the ability of the gas to move between the bloodstream and then whatever is in alveoli. So it's affected obviously by the thickness of alveolar capillary membrane, which can be affected like in interstitial lung disease. It can be affected. If somebody has a pulmonary edema, this will go down. Loss of alveolar surface also will decrease this function because you have decreased total surface of the alveoli. And then if you have, for example, more red blood cells, then it also will be happen more effectively because your body will have capacity to get more oxygen or like more gas. Uh, the DLCO increases during like exercise because you have more flow, left to right shunt because also there is more blood flow, and polycythemia because you have more red blood cells. During respiratory maneuver fraction, so basically you're tracing how much CO2 is when you inhaling, and then how much CO2 is when you're exhaling. Okay, so and then you see the difference. There is a formula they calculate, and then that's how you calculate diffusion capacity. So interpretation will depend on it's difficult to use any single separate number without the context of the patient and the context of other tests. So there are conditions which you need to think about, like when interpreting diffusion capacity for the carbon monoxide. It will be lower among cigarette smokers because of the presence of carboxyhemoglobin, so it competes with CO2. It's gonna it can be lower with some of the obstructive diseases like emphysema because you have less surface for the gas exchange. It can be lower with restriction, for example, with the interstitial lung disease or pneumonitis because of this alveoli will be thickened. And then you may have normal DLCO with a restriction, for example, with a pleural effusion, which creates like external pressure, but the exchange of the gas in the certain area will be still preserved. So, and then it could be low diffusion DLCO with a normal spirometry, for example, the pulmonary emboli, anemia, when you have either decreased blood flow as a pulmonary emboli or decreased amount of red blood cells to capture the oxygen to capture the gas. So these are the types of lung disease. There is obstructive, and the hallmark is a decreased forced expiratory volume in 1 second ratio to forced vital capacity, and restrictive, reduced lung capacity. And then, as a lot of, well, probably even most things in medicine, there'll be some mixed picture, and it's going to be difficult. Like many people will have something mixed rather than just one pathology. So COPD, right? So we talked about the definitions yesterday. It's a long-term airflow obstruction, which is not fully reversible. It's partially reversible. So that's why patients still going to use like albuterol or muscarinic blockers. So clinical definition is there's a presence of chronic productive cough of 3 months during each of 2 consecutive years. So it's a clinical diagnosis for COPD, and then there are two patterns, which is chronic bronchitis, which primarily affects the small airways, and then emphysema. So the hallmark is a decrease of the FEV1 to FVC ratio. So prevalence of COPD. Remember, prevalence is how many patients you actually have at the moment. Okay, this is 2019. It probably didn't change too much. You can see it's still pretty common, like in US, where you're gonna have your clinical rotations, and then some parts of the Europe, and then in Australia. So one of the explanation is that at certain point in the past, the smoking was very, very common. It's not very common now in US. And people who damaged their lungs like in 70s, 80s, they're still alive. That's why. And then right now, they actually, many of them develop COPD like years after. So that's why the prevalence is still high. And then it also correlates with the just general life expectancy. If life expectancy in certain country, for example, is like 50, nobody lives in the like 70s, 80s, then of course the prevalence of like this COPD will be lower because you need to live, you need to have certain amount of exposure, certain amount of lifetime to get to the point where you're officially diagnosed with COPD. So yeah, we talked about this also yesterday briefly. So this is the lung function over the lifetime. You see the lung function represented by FEV1. So normally in the upper line, if patient doesn't smoke, doesn't have any predisposition to the COPD, then they never really reach the degree of the lung function drop, which causes the symptoms. Okay, so you can see it never gets to the symptoms part. But if somebody's smoking, the same line goes down, and then symptoms here on this graph are like shown when like somebody gets like around 60 years old and gets symptomatic, and then if somebody keeps smoking, which is not unusual, many people will be surprised with COPD on oxygen they'll still smoke. So then they get to the disability point quicker. So if anybody stops smoking at the certain time, like at the 45 or 65, it's still helpful uh, you will not reverse the damage was already done. But the loss of function, the speed at which you lose this function, will go down, and then you'll get symptomatic. You may not get symptomatic, or you may get symptomatic like late in life, which is still better than like continuous smoking. So, what are the main risk factors for COPD? So the main, of course, it's environmental. It's cigarette smoking. The other stuff people smoke now, like vaping and marijuana, like there is not like any clear data yet because you need to observe people for the longer period of time, but they probably these factors as well. Uh, of course, if there is a lot of pollution, occupational exposures, uh, somehow allergy and asthma is also predisposes the patients to COPD. Uh, Something congenital like abnormal lung development, bronchopulmonary dysplasia may predispose COPD, childhood infections, TB, and then some genetic risk factors like if you lose the function in alpha antitrypsin deficiency or you have mutation in the cystic fibrosis gene. So a few words about pathophysiology. So these are the processes which affect the affect the patient, the main pathological processes which affect the patient, which lead to COPD, okay, and the symptoms. So first of all, smoking and other factors that cause. I'm not smoking. I'm just recovering from flu from 2 weeks ago. So there is a chronic inflammation, which is one of the main factors. So there is a long-term exposure to irritants like smoking or pollution, and then it causes the inflammation of the airways, alveoli, and pulmonary vasculature. So this leads to airway remodeling. There is more inflammatory cells. Uh, these cells release proteases, causing fibrosis, narrowing and like thickening of the airways, which causes narrowing of the airways. There is a mucus hypersecretion. That's why a lot of patients with COPD they have a lot of like chronic cough, and then it's worse in the morning because it all accumulates and they have to cough up this phlegm in the morning. So there is a goblet cell hyperplasia, which they produce the mucus, leading to airway obstruction. There's a little bit different mechanism in emphysema, which is the destruction, basically loss of alveolar walls. Uh, this causes loss of elastic recoil and gas exchange. You remember, so inhalation is an active process, right? You need to contract the muscles to bring the air, but then all the muscles relaxed, and by own weight, the lung and the chest wall is kind of recoiling. So that happens with the alveoli. Okay, so if you lose the elastic recoil, then the alveoli remain open. You have air trapping. These open alveoli they kind of obstruct the small airways. So that's how the gas exchange get impaired. And then at the latest stages of COPD, which not everybody develops, only with the severe COPD, patients may develop like a pulmonary hypertension, uh, primarily from the hypoxia. Like anytime in anywhere in the body, hypoxia will cause vasoconstriction. That's a normal reaction. In the pulmonary vasculature, there will be imbalance between nitric oxide, prostacyclin, thromboxane. So nitric oxide that dilates the vasculature, right? So there will be, because of the oxygen deficiency, the hypoxia, there will be more factors to cause vasoconstriction. This will increase the pressure in the flow. Uh, Eventually, that causes the right side heart failure, and corporal manali is basically the same word. So you can measure the pulmonary pressure with the echo, but it's not very accurate. You need to have really right side heart cath to have the accurate numbers for the measurement. So just a few words about emphysema pathophysiology. So it's characterized by abnormal and permeable enlargement of the lung air space with the destruction of like the septi between alveoli. They became like a one bigger sacs, and you can see the difference between normal and alveoli with emphysema. So then the air trapping will happen there, and then the surface for the air gas exchange will be decreased as well. So again, like few words about emphysema separately because it's that physiology is a little bit different. Um, so the what happens is the air trapping and hyperinflation. So loss again, like as I told, like loss of elastic recoil prevents alveoli from fully deflating, leading to the air trapping, right? And then it also prevents the gas exchange because the air with a high concentration of oxygen doesn't get to alveoli. Uh, at the gross level, like at the when you put everything together, or I call the small alveoli together, this will increase the residual volume and total lung capacity, and then at the advanced cases will cause the barrel chest appearance. The same process will push the diaphragm down because the volume will go up, and then you'll see the flattened diaphragm. Again, this will be in advanced cases, like mild COPD will have like normal chest X-ray and then minimal symptoms. It causes small airway collapse and increased airway resistance. Uh, and then this leads to shortness of breath and then impaired gas exchange, reduced alveolar surface and pulmonary capillaries leads to hypoxia. And then in later stages, hypercapnia as well. So hypoxia, it's because they have decreased surface for the gas exchange. And then hypercapnia is the develops from decreased ventilation. So just like this will be coming up frequently. If you have hypoxia, that's gas exchange, and then hypercapnia is ventilation. Okay, and then VQ mismatch happens, ventilation perfusion mismatch, because there will be areas where there's a blood flow, but there is no the airflow, and could be opposite. So this is how the COPD small airway is going to look with the normal on the left side and then a COPD on the right side. So you see the difference is that there is some remodeling of the airways. Uh, there is a yellowish stuff you see. There is a mucus production, which is done by the goblet cells, and then we have more goblet cells, which produce more sputum. And normally, if there is a sputum, it's moved up by the ciliated cells, and you have loss of those cells. So that's why not only producing more phlegm, it's more difficult to evacuate it out of the small airways. Um, Also, smoking usually primarily causes the squamous cell metaplasia, which can be considered like precancerous condition, because that kind of epithelium shouldn't be in the airways. Uh, so yeah, so that's what you have in the small airways under like on the microscope. Okay. Here they also showed more uh, smooth muscle cell hyperplasia as well, which makes the airways thicker. So of course you can guess like anybody with a pulmonary disease basically will have shortness of breath, right? So and your task will be to figure out when it happened, like ask specific questions about the breathing problems, how it happens, morning, evening, how much activity, what is the baseline. Uh, so you have to ask all these questions. And at the beginning, it will have shortness of breath only will happen with a significant exertion. Uh, and then even at rest, people may have uh, shortness of breath with advanced disease. So patients will have cough, sputum production, a little bit less common. They may have chest tightness and wheezing, especially with the times of exacerbation. So how you make diagnosis? Of course, you ask the detailed question, and then symptoms may present. Patients may present different ways. Somebody would like minimally active, like obese, and then they may have more advanced COPD because they think they're just like out of shape and they may not seek like medical attention until it's more advanced. Somebody may present really early. Somebody's exercising and notices like they could run like 5 miles, then now cannot run more than 3 miles. So they may present like at earlier stages in the disease. So an exam, like most of the time, will be probably just normal. because we talk about like extreme cases with barrel chest, but that's really patients usually present before that happens. You have decreased breath sounds because of emphysema. You have just decreased less amount of lung. That's why you have less sounds. And because of the airway narrowing, it will take more time to exhale the air out of your lungs. That's why you'll have prolonged expiratory phase. You remember normally you have uh, expiratory phase is like shorter, but here it will take like the same time as to inhale. Uh, you may hear wheezing on exam. During exacerbations, may see use of accessory muscles. If that happens, usually people require hospitalization. Uh, and then barrel chest again, like if it's advanced COPD. So spirometry, how we diagnose? Of course, we take detailed history, we do examine, ask about smoking history, exposure to different environmental factors. If somebody's younger, especially not smoking, you need to look at about other reasons like alpha-1 antitrypsin deficiency and some other genetic possibilities. So in spirometry, the ratio of FEV1 to FVC should be less than 0.7 post bronchodilator. Okay, so that's the first measurement, and then to classify COPD as a mild to severe, then you look only at FEV1. Okay, you don't use the ratio anymore. You use the FEV1 to see the severity of the disease. And GOLD means the Global Initiative for the Chronic Obstructive Lung Disease. So again, this is spirometry, as we had this similar picture before. You see in a normal curve, in 1 second, if you try to exhale quickly, most of the air will be exhaled within first second. In COPD, like in asthma, is the same. You cannot exhale that much during first second because of the obstruction. So it takes more time to eliminate the air from the lungs. So these are the labs you will do. So what's going to happen to hemoglobin with the COPD? Hemoglobin will be normal, higher or lower. So it can be normal. It can be low if somebody has like some other problems, like iron deficiency or some other chronic problems. But it may be higher because the response to hypoxia will be producing more red blood cells. Okay, that's why. Uh, but then if it's really out of proportion high, you need to think about rule out other possibilities like primary polycythemia, for example. But some degree of hypoxia will stimulate red blood cell production. So that's your body's adjustment. You'll need to check electrolytes with creatinine, because again, like if somebody's short of breath, you need to look at other reasons. TSH is a thyroid stimulating hormone, because if somebody's hypothyroid also may have like shortness of breath. You look at other causes which may cause the shortness of breath, and proBNP is not ideal blood work, but you can just check it to evaluate for the COPD. I mean for the CHF, for the heart failure. You'll do ABG, which is arterial blood gas, which will show hypoxia. Hypoxia may be seen in the early stages, uh, and then hypercapnia doesn't happen at the beginning, but as the ventilation becomes a problem, uh, that will show up as well. And hypercapnia will cause a respiratory acidosis, right? So especially in the exacerbations, so your pH will be below normal range, okay? Because you retain CO2, which goes into acid production. And then if this history is not very consistent for the, like, it's not very, doesn't really match, like typical COPD patients may check out the stuff like alpha-1 antitrypsin deficiency. You'll do chest X-ray, and then most of the time it's just probably going to be normal unless it's like flare up or there's a pneumonia at the moment. But you still need to baseline X-ray to have like a baseline, because patients will be coming to you again and again, and you need to have something to compare. If it's more advanced COPD, you'll see flattening of diaphragm. You may see bulla. CT will show emphysema. Also may help to evaluate different complications of COPD, like it may show like bronchiectasis, bulla, some other pathology like cancer. So that's how emphysema looks like on the chest CT. You can see the black areas, the lucencies, like that's basically the absence of the lung there. Okay, uh, this is advanced COPD, more upper lobes. You see there is kind of empty space in the lungs instead of the lung tissue. So, quick case. So 61-year-old man with a COPD, not on home oxygen. So that's when you ask the questions, when somebody have established diagnosed COPD, you need to ask the questions about their baseline, if they're on oxygen, how much oxygen they use, how much they can do. You can walk like 5 minutes, can they walk to like to the second floor? So to have like understanding of the basic of the baseline. Presents with 3-day history of worsening dyspnea, increased cough frequency and production of thick yellow-green sputum. He reports increased fatigue, decreased exercise tolerance, and wheezing. He denies chest pain, but mentions a low-grade fever and chills. There has been no improvement with his usual bronchodilator therapy. So these are his vitals: low-grade temperature, heart rate a little bit high, respiratory rate also high, blood pressure slightly above normal. On the exam, you hear you see. So you part of the exam is observation of the patient, okay? And you can learn a lot just from looking. Somebody just visually in distress, holding like the table, or cannot just sit quietly and just in distress. So that's one of the criteria, like one of the factors you're looking at. So on the exam of the heart, there is tachycardia with no murmurs. There is a diffuse wheezing on the lung exam with a few crackles, no edema on the legs. Chest X-ray shows hyperinflated lungs, no consolidation or pleural effusion. So what do you think is the diagnosis? Like what happens? What's happening here? Yeah, it's COPD exacerbation. Okay, and then infection is one of the most common reasons why this would happen. Another common is like people keep smoking, or they try to stop and they have like few cigarettes and then this happens. Um, the Sometimes you don't know why it happens. Like people just have like a flare up and then you ask all these questions. Like there was no any recent viruses, infections, they don't smoke, but it still happens. So and then if you work in the hospital, like inpatient, that's how most of the time they're going to present. Okay, if you're working outpatient, you'll be seeing them more like in the stable condition when you're just talking about the everyday life. But in the hospital, they come the acute flare up, and we'll talk about like treatment of the COPD exacerbation a little bit with the when we talk about treatment. So a few words about alpha antitrypsin deficiency. It's a genetic disorder that can lead to lung and liver disease due to the lack of protein called alpha-1 antitrypsin, which protects tissue from enzyme damage. So alpha antitrypsin deficiency is autosomal codominant. Codominant means like both alleles produce the protein, okay? And then it's caused by different mutations on the chromosome 14. The spot is the same, but type of mutation can be different. And then depending on the mutation, it can be reducing the amount of normal protein more or less. Um, if you have both alleles with a severe reduced, then you'll have obviously a really bad disease. If you have one normal allele, you may be like, could be asymptomatic. And an inheritance pattern is like both parents need to pass on a defective allele for the disease to manifest severely. Because if you have one allele, should be sufficient enough to produce enough protein not to develop the disease. So what happens with the alpha antitrypsin deficiency? Normal function of alpha antitrypsin is to inhibit neutrophil elastase, an enzyme that degrades elastin in the lungs if left unchecked. So it prevents like autodigestion basically. And then about the lung damage in deficiency, neutrophil elastase is unopposed, so you have too much of it, leading to destruction of alveolar walls, resulting in pan-acinar emphysema. So when you see pan-acinar, like for the questions for the test, you may click with the alpha antitrypsin because uh, it's kind of it's typical, but not the only cause of pan-acinar emphysema, particularly in the lower lobes. So neutrophil elastase induces also mucin production and secretion and increased expression of other proteases, and you have more inflammation going on. Alpha antitrypsin is a potent anti-inflammatory, and you have less of it. Uh, regulate also neutrophil chemotaxis like attraction, degranulation, autoimmunity. So it regulates a lot of processes in the lung tissue. So you don't have enough of this in the lung, but you have too much of alpha antitrypsin abnormal in the liver. Okay, so because that's where it's produced, right? It accumulates in the liver, leading to the damage, cirrhosis, and then anybody with cirrhosis has increased risk of the liver cancer. I think it's a little bit smaller, but this is just a picture of what we talked. So the first left upper part, that's what happens in the liver, right? So you're making alpha antitrypsin, but it's not normal, malfunctioned. So it accumulates in the liver, and then you can stain liver tissue with the acid shift. That's the stain, and then you'll see the inclusions. Okay, so this abnormal alpha antitrypsins remains in the liver, and you have on the this part you have less of it in the lung, and that causes emphysema. But and that's in the middle. You have some description of pathophysiology of alpha antitrypsin. You see, you have too much uh, of neutrophil elastase, which affect different processes, basically causing the inflammation and then increased mucus production. Uh, so how we diagnose? We check the level of alpha antitrypsin in patients with the COPD, liver disease, difficult to treat asthma, and then if you have close family members with the alpha antitrypsin deficiency. Also need to check CRP, C-reactive protein, because alpha antitrypsin can go up a little bit with it's a acute inflammatory molecule which will go up with the inflammation. That's why if CRP is really high, maybe alpha antitrypsin could be a little bit, the level could be a little bit changed. Okay, if it's low, it's low. Okay, but if it's high, you need to correlate with the CRP. So in terms of treatment, unfortunately, it's not great. So you need to control other risk factors because these people still could be smoking or doing other damage to their lungs. May have like environmental exposure, like work exposure. You do the standard COPD treatment, and then you do IV plasma purified alpha antitrypsin. You have to infuse it like regularly just to support the lungs. And then I think it's not going to affect your liver function because you already have too much. So it's primarily protect the lungs, but I don't think it's going to change the course of disease in the liver, which in general, that's a problem. In advanced cases, you may consider like lung transplant or liver transplant if it's like early cirrhosis. So we'll talk about the treatment of asthma and COPD. So both of them are obstructive lung diseases, right? So that's why a lot of treatments we're going to use for asthma and COPD going to be like similar. So in the middle, we have the group of medications which you use for both diseases. And by the way, asthma and COPD may be in the same patient, right? So, and sometimes there is like big overlap and you cannot differentiate is it asthma, COPD, or both. So, uh, so in the middle, we have short-acting beta agonists. And then the most common is the albuterol. So remember, when you have like, when you activate sympathetic nervous system, your body is ready like to run. So to run, you need to have to dilate the airways, you need to have more oxygen supply. So that's why you stimulate sympathetic nervous system, and then you inhibit parasympathetic because when you're parasympathetic, your vagus is more active. Your body is kind of a more quiet state, like ready to digest the food and relax. and you don't need so much like oxygen supply. So that's why you need to block that processes in your lungs. So besides short-acting beta agonist albuterol, which will work quickly, there is a long-acting beta agonist. They will not work quickly, so it cannot be used in the acute episode. Okay, they're used for the maintenance of your airways, either in asthma or COPD. Long-acting, any long-acting medication just will keep it open. Okay, we have short-acting muscarinic antagonists, which is ipratropium, is one of the like of these medications. We have long-acting muscarinic antagonists. Also, what we have common is anti-inflammatory, which is primarily steroids. And then we have inhaled steroids, which can be used both for asthma and COPD. They are more frequently used for the asthma, but in COPD can be used as well. The problem with inhaled steroids, they increase the risk of pneumonia a little bit because it suppresses the local immune reaction. So chances of pneumonia goes a little bit higher with inhaled steroids. Uh, if somebody comes with a COPD exacerbation, like in the case we talked a few minutes ago, then may need to use systemic steroids, either oral or IV. Also can use methylxanthines, which are not frequently used anymore because we have other options, and they use as the primary effect is bronchodilation. But they may interact with other medications and they're not very effective. So then in the patient, like in our case, may need something called non-invasive ventilation. Okay, if you do blood gas and your CO2 is really high, that means you're not ventilating. Somebody develops respiratory acidosis with pH being below the normal range, like below 7.35, then you may need to use non-invasive ventilation as a next step. So you know what is that, right? You put the mask, uh, and then it's kind of the same as intubation, but instead of the tube being inside like of your airways, the ventilation happens from outside. So that the mask sitting tightly on your face, they adjust the size to your to the patient, and it's biphasic, so it helps you to breathe. So when patients initiates herself the breathe, the BiPAP machine will push more air, okay, and then patient exhales. There is some baseline rate, maybe like 10 a minute when of the machine. If patient is not initiating any inhalation, like it will try to push it, but usually just supports patient's own breathing. So, and the patient should be awake to do this. If somebody's unconscious, it's not going to work very well. If somebody has like face like trauma, also going to be difficult to use. If somebody is like nausea and vomiting, also cannot be used because like you cannot sit with a tight mask on your face if you have like vomiting. So, and then oxygen is the really important part of the treatment. So for asthma, oxygen is used only with the flare-ups. You don't need oxygen like chronically. But somebody develops advanced COPD, may need to use oxygen like on daily basis, 24/7 basically. And then in those patients, oxygen is the only thing which increase the lifespan, okay? Because it kind of prevents a lot of pathological processes. It treats the pulmonary hypertension, have less hypoxia, so that's how it helps. If we look about the at the asthma only medications, then we have leukotriene receptor antagonists. So you remember leukotriene pathway is one of the like inflammatory pathways, so you block that. Montelukast is one of these medications. It can be used as a pill. Uh, there are biologics. There are different types. One of the first ones and most common probably is anti-IgE. So, and you will not use it with anybody with asthma. Okay, you need to have. There are two types of asthma. There is like atopic, which is related to atopy allergic reactions, and then non-allergic, right? So you check the IgE level. If it's really high, then you consider treating with the biologic, which will decrease the IgE level. And in many patients, this really helps. Somebody, for example, can be like having exacerbations every month, taking like steroids 3-4 months a year, which is really bad long term, and then start using biologics, and then it helps. In ED, asthma patients also may end up using IV magnesium, which relaxes the smooth muscle. Um, so these medications used like particularly for the asthma, and for the COPD, there is a phosphodiesterase 4 inhibitors like roflumilast. It's not used for acute flare-up. It's just used as a supportive. It's not like super effective, okay, and it's not like first-line treatment. And that antibiotics can be used in COPD in few different situations. So if somebody has the frequent flare-ups of COPD, they may use antibiotic called azithromycin 3 times a week to decrease the amount of exacerbations and to decrease the hospitalizations, okay? Um, and then antibiotics can be used in the acute setting when somebody has flare-up due to infection. So you have somebody has more phlegm, fevers, um, even without pneumonia, short course of antibiotics can be used. The previous results of the sputum culture may be helpful if somebody has like Pseudomonas. There is a high chance they're going to have Pseudomonas again. Otherwise, you'll send the sputum culture and see what's there. But empiric antibiotics also can be used, like doxycycline or azithromycin. So that's the treatment. This is just like the classes, the groups of medications, okay? And then you go stepwise. So both COPD and asthma, you go stepwise treatment. So in COPD, you start, uh, again, this is just symptomatic treatment. If somebody diagnosed with COPD but have no symptoms and that is not willing, doesn't need like medications, may just leave without treatment, okay? So at the beginning, you can use like short-acting beta agonists and short-acting muscarinic antagonists, like basically like anytime during the treatment. That's why they're all the way through. And then as the symptoms getting out of control, you add other medications. So you add long-acting medications, which are long-acting muscarinic and beta agonists. If it's not enough, you may add both of them. It's going to be long-acting beta agonists like salmeterol and long-acting muscarinic antagonists like ipratropium. And then, if it's still not enough, and then you may add inhaled corticosteroids. And then if it's still not enough, may add may group all three of them. And there is the inhalers which combine all 2 or 3 medications. So it's like one inhalation like twice a day, and then patients will get all 3 medications with one puff. That makes just more convenient rather than using different inhalers. Yeah, and here we have other additive medications like roflumilast, azithromycin for frequent exacerbations. Mycolytics are not really so effective, especially if you use them as oral. And then oxygen will be added later also if somebody is consistently hypoxic. So you will check the oxygen level in the like quiet conditions. Somebody's just sitting, and then you'll check the oxygen level saturation just with the walking, right? So the criteria is usually for the insurance company to approve, and that's how it made it in studies. Is if the oxygen drops below 88%, then you will need oxygen supplementation. You'll benefit from it. Some people will just feel short of breath, right? And you check the oxygen level and it's normal. So people may have other conditions, like they may be deconditioned, they may be recovering from flare up, they may have like bad obesity or like joint pains. So that's why you need to see that shortness of breath is actually from hypoxia rather than from anything else. And with asthma, is the same principle. You just use the medications a little bit different sequence. So the goal with the asthma treatment is really that it should be to control to the degree when patient needs short-acting beta agonists like albuterol puff, like infrequently, right? If somebody uses like albuterol once a week, that's kind of the goal, okay? And not never waking up at night with shortness of breath. So that's the goal. That means asthma is controlled. If it's not controlled, you keep adding the medications, okay? And then here you start as a first step when it's very mild and intermittent. You can use the albuterol short-acting beta agonists, especially if asthma is just like provoked by something specific, like by exercise. You use it before exercise, or if it's a cold, then you use it like before going outside. And then you use inhaled corticosteroids a little bit earlier because the mechanism for the asthma is like more inflammation, right? So that's why you use inhaled corticosteroids at the earliest stage. Um, and then you add the long-acting beta agonists. You add the long-acting inhaled corticosteroids. Like actually, all inhaled corticosteroids are long-acting. So you keep adding things like biologics. And then if it's really difficult to control after you escalate to the couple steps, then usually people get referred to the pulmonary specialist so they can have another look, kind of second opinion, and then maybe start biologics because most of the time you need pulmonary specialists to approve it through the insurance for the biologic. So, and then if symptoms are well controlled for a long time, you may go up, step down, or if it's not controlled, you may step up. Okay, it can move both ways. Sometimes if it's like early childhood asthma, it gets better on its own with adult life, and then you may like de-escalate the treatment. So I think that's it. So this is the literature I used. Um, so thank you. Like questions? Thank you. Yeah. You cannot cure asthma. You can treat, but you cannot cure. No. It may get better if it starts in childhood, and it may get better on its own. Uh, and it may get better if you somebody figure out like cat or dog like is causing the kind of allergic reaction. That's why you have the asthma flare-ups all the time. But then you may just like it's not going to be cured. It's still going to be there, but you may have no symptoms without any treatment. Because if I think in those patients, if you do like biopsy, and you're still going to see some changes, like it's not going to be exactly normal. But patient may have no symptoms. And COPD is the same. It's like it only goes one direction. It's not curable. Any question? You're thinking about something. Right. Okay. Thank you then. Thank you.